afternoon, everybody. Thanks for joining us. I know we'll have a few more trickling in as they arrive, but we'll go ahead and get started so we don't hold anybody up. Today we are doing our fourth series, I believe it is, in our Learning Collaborative. And it's going to be on social determinants of health, including the Z codes and EHR codes. And Shannon Chambers is here to present for us. So we thank you guys for that. We hope everybody had a great holiday season. And we're just happy to have everybody back. And we're looking forward to this new year. We're going to start with some introductions. And I think everybody knows everybody, but we could go ahead and just do a real fast introduction. That way Shannon gets to meet everybody. So if we can start with our team, I'm going to start with Sydney, if you want to go ahead and start first.
Good afternoon, everyone. My name is Sydney Fleming, and I am the Outreach and Community Engagement Specialist on the Constellation Regional Collaborative team.
Sylvia?
Good afternoon. It's nice to see you all and Happy New Year. I'm a strategy consultant with the Constellation Regional Collaborative and a transformational coach for the Learning Collaborative. And I'm thrilled to see some of the Novant Health team here for the session this afternoon. And Erica did text and say she was on her way.
I'm Kathleen Wellman. I'm the program coordinator for the Constellation Regional Collaborative. So it's nice to see everybody again. Maxine Arena, who's our program manager, is not here today. Unfortunately, she's out with a family emergency. She does apologize for that, but she does wish you guys all a happy new year, and she'll be back for our next session. Okay, let's go ahead and start with our faculty then. Dr. DePetty, would you like to start us off?
Well, sure, Kathleen. Thank you very much and Happy New Year. And thank you for having me. Obviously, I'm Don DePetty. I'm a physician, primary care internist, but also trained in hypertension and cardiovascular disease. In addition, I'm the advisor for the collaborative, predominantly also sit on the Constellation board of directors. And my involvement has been connecting our organization and the enterprise with others, such as the Southern Medical Association, where I've been past president, my institution, University of South Carolina School of Medicine, where I'm past dean, and also the Pan American Health Organization and the World Health Organization in their global initiative to approach hypertension, management control, and now expanding into diabetes and kidney disease.
Thank you,
Kathleen,
Dr.
could you please, I don't have permission to do it. Could you please let Erica Ann for us?
She is not in our waiting room.
She's not. She says I'm here. So
She's on
just
I think she's on Teams. I messaged and said we're over in Zoom, so have her pop in.
Okay. Okay. All right. I'll let her know.
Thank you, Sydney. Okay, let's go ahead with Shannon, if you would like to go ahead.
Sure. Hi, my name is Shannon Chambers. I currently serve as the Senior Director of Provider Solutions for the South Carolina Office of Rural Health. So in that role, it's everything from billing, coding, compliance, and all things that fall under anything rural for providers in South Carolina. Additionally, I am the current president for the National Association of Rural Health Clinics. So rural is definitely a passion, and I'm excited today to talk to you a little bit about social determinants of health.
Great. Thank you, Shannon. Okay, and then we have one of our transformational coaches, LaShonda, correct? Did I mess your name up?
No, that is correct. It's LaShonda.
Okay, thank you. I'm so sorry about that. LaShonda, if you'd like to introduce yourself.
Sure. My name is LaShonda Petaway Brown. I am a practice transformation consultant at the South Carolina Office of Rural Health. And what we do is all transformation with primary care practices in rural and urban areas.
Great, thank you so much. And then Joy, if you'd like to introduce yourself. Joy may not be where she can introduce herself.
Oh,
there you
sorry.
are. You're fine.
I just took a bite of my crunchy food and I didn't hear you say my name. Sorry. My name's
I trained for a waitress, so I waited until you put your food in your mouth. So.
Yeah, it was like, sorry. My name's Joy Dahl and I support the Iowa Community Hub as social care advisor, and we are supporting Constellation Quality Health on their development of a community care hub. So I do a lot of work in this space.
Thank you, Joy. Suzanne?
My name is Suzanne Sonneman, and I am a community paramedic with Novant Health at Wilmington, New Hanover County, and I go out, do outreach for patients, go to their house in rural areas as far as I may go. It's about 40 miles out, and take their vital signs, talk to them about nutrition and all the things they can do to improve their health, especially hypertension. I have mostly stroke patients, post-stroke patients. And yeah, that's what I do. I've been a paramedic for 30 years now. And I do the community paramedicine for the past 5.
Thank you so much.
And I'm on Erica's team.
Perfect. Thank you. And Lauren?
Hello, my name is Lauren Stevenson. I am with Novant Health New Hanover, also with Suzanne and Erica's team. My role is Neurosciences Performance Improvement Manager, so I support the stroke team, and just excited to learn more through the call today.
Thank you. And then I saw Catherine Plunkett snuck in. She's one of our lead coaches also. Catherine, did you want to introduce yourself?
Hi, good afternoon. Catherine Plunkett. I'm a quality advisor with Constellation and looking forward to this presentation today.
Great. Thank you so much, you guys. All right, so just some friendly reminders. If we can keep our microphones on mute when we're not speaking, just so we don't get any background noise during the presentation. We'll have you use your chat function or your hand raise function during the session, and Sydney will be monitoring chat for us. So she'll go ahead and keep an eye on that. So that way we'll have someone, keep monitoring. Sorry. And please note that all the sessions are recorded. We go ahead and scrub these to make sure there's no PHI at all accidentally released. And then we do go ahead and upload those to our Constellation YouTube channel. So they will be available for future viewing if need be. All right, so I'll do just a little background on Shannon, even though she went ahead and did it. But so our presenter is Shannon Chambers. She joined the South Carolina Office of Rural Health in 2011 and serves as the Senior Director of Provider Solutions. Provides technical assistance to the rural health clinics in compliance activities, billing and coding, EHR implementation, and practice management. Prior to joining SCORE, Shannon worked in multiple physician practices. She has experience in family practice, internal medicine, orthopedics, urology, pediatrics, and many other specialties. She's a certified professional coder with the American Academy of Professional Coders, an AHIMA-approved ICD 10 CM PCS trainer, certified revenue cycle associate, a notary republic. She serves as the vice president for the National Association of Rural Health Clinics Board. So we welcome you and thank you so much, Shannon. Let's go ahead and get you started.
Absolutely. And apparently I need to update my bio on our website because as of January 1st, I'm the president for the National Association of Rural Health Clinics, which was a great honor to get that updated. So I appreciate that. So today we're going to talk a little bit about social determinants of health. We're going to talk about EHR optimization and how to utilize your EHR to really start to meet this. Next slide, please. So what are social determinants of health? They're everything such as poverty, access to healthcare, lack of education, stigma, racism, and lack of food. All of these are contributing factors to health inequities. It's important to consider what factors are impacting our patient's health. Because if we have a patient that has diabetes, but they don't have access to food, healthy food options, then are we really making an impact on that patient? We want to identify and address social determinants of health to really help improve that health status of the patients and the populations that we serve. Here's the interesting one, right? So social determinants of health have been shown to have a greater influence on health than either genetic factors or access to healthcare services. Where you're born, where you live, where you learn, work, play, and age, those are all social determinants of health. Next slide, please. So there are a lot of resources for provider education. So what we do here is, as part of some of the work that LaShonda and her team do, it's everything from making sure that our clinics and our providers have what they need, but it's also making sure that folks understand the ways that they can implement things. So are the providers comfortable with addressing social determinants of health? Do they have access to resources to provide to patients if issues are identified? So what I've given you here, and I'm not going to read through all of these, but if you don't know about these top three first, these are fantastic resources to have in clinical settings. Everything from the Navigator to Aunt Bertha to Find Help. All of those allow you to put in a zip code. So I put in my own personal zip code, and I don't live in rural, I live in urban. And everything from I can get access to bus passes, I can get access to assistance for housing, food, and where even the local food pantries are, as well as the free pantries that pop up in a lot of the neighborhoods that folks will put up. But these are some great resources. The other one is the AAFP, so the American Academy of Family Physicians, has an awesome tool called the Everyone Project. That toolkit is a great resource if you haven't started social determinants of health, is really something to do as education for staff and or providers. Next slide, please. All right. So we need to collect social determinants of health. How do we do it? Well, we can do it before, during, or after a healthcare encounter. There are several tools, and you're going to get access to a lot of links today for free tools that you can download. And that's those health risk assessments and screening tools. Coding professionals can utilize some of this information, the social information from social workers, those community health workers, case managers, or even the nurses to include in the official medical record. We can intake that. So sometimes maybe it's that we give the patient the form once they check in and we have them complete it. There are several ways, and we're going to talk through some that we've kind of found that work the best. And then we really should be screening for those social determinants of health information at each care encounter. Next slide, please. All right. So for office visit levels, and I know that CPT coding was not included, but we're going to give you a little bit of that as well today too. So if the provider is using data that is related to social determinants of health, it can actually make the medical decision making harder. So for example, a patient that has diabetes doesn't have access to healthy food options, or maybe a patient, because we are located in the South, and even though it's cold outside right now, a patient that has congestive heart failure. If they don't have air conditioning, then maybe we're seeing more swelling, and maybe we're having issues such as that. And of course, the medical decision-making is really what is used now to determine that level of visit. We all remember when it was actually the review of systems, and we had to go through and say how many we did and how many we looked at and what was normal, what was abnormal. Now medical decision-making is what that key driver is that is pushing that office visit level forward. You can also utilize a checklist that the patient completes, and we can do everything from that's happening kind of outside of medical. CMS has a checklist. There are 26 questions. And the first time that I started talking about social determinants of health, I was like, dear Lord, that's 26 questions. Like, we can barely get them to turn in their new insurance cards on time. But really, it's making them accountable for some of the things that are happening in their life as well. So I kind of wanted to talk through is, if a patient's coming in for a quick, easy visit and we're talking about maybe hypertension, well, what else is impacting that patient? Or cardiovascular disease, for the example that we're going to use for this session today. But what else can impact? Well, maybe I don't have access to clean water. Maybe I don't have access to things like that. Those are all going to impact. Next slide, please. All right, so here's the awesome little checklist that is available. There's another one that I really like as well, and it's the second one there. You can actually customize this tool to your clinic. You can put it on your letterhead. You can remove the information that you're not needing. While the patient is being checked in, they can be given the form. The nurse can take the form, review it for any potential risks, and actually make the provider aware. The other thing is that's key here is if you are using a checklist that is not in your EHR, please scan it in, make it a part of that patient's medical record. As an auditor, that's something if you address it in the note that you went over social determinants of health, I'm going to go look for that because I want to make sure that if you're addressing something that it's been scanned in as well. The other thing here is that with templates, so if you are on some of the bigger systems, or I'll use Epic, for example. If you are on Epic, then there's ways to actually incorporate your social determinants of health in there. It'll actually pop up into the population health tab on Snapshot, and you can actually put that information in and actually see what you've addressed prior with the patient. Next slide, please. So how do we code for it? How do we get paid? Because I think part of it is that everyone's like, yeah, we'd love to be able to do that. It takes a lot of time, but we're not going to get paid for it. So CMS actually has a standalone code, which is that G0136 for the assessment of social determinants of health. This is described as an administrative of standardized evidence-based social determinants of health risk assessment. It's 5 to 15 minutes. We cannot do this any more than every 6 months. The risk assessment is in relations to the patient's social risk factors that influence the diagnosis and treatment of those medical conditions. Here is the key that I wanted to make sure I put on here for those that you might be in a hospital setting. It is performed in an outpatient setting. The exception is a discharge visit. So if we're discharging a patient, whether that's our discharge from the hospital, we're discharging from nursing home, etc., then those social determinants of health should have been addressed prior to discharge. Next slide, please. All right. So incorporating social determinants of health data into EHRs. It can drastically increase your scope, the quality, and timeliness of data that is available for interventions for those patients, right? There are tools that you can utilize. I've tried to give you a lot of access to information because I think sometimes there's nothing worse than listening to a presentation and someone talks about all of these tools, but you don't get access to any of them. So I've tried to make sure, and I know that Kathleen will make sure the slides are available to you as well. But Thrive has an awesome tool out here. And the WeCare model, which was actually out of the Boston Medical Center, they've got a great one as well. So we know there are, 100 different EHRs. It also depends, especially in our rural practices, a lot of times, is they may not have the most sophisticated Epic, eClinicalWorks, etc., or Cerner. They may have a smaller product that does not necessarily have the capability to pick it up for social determinants of health. there's actually an EHR association, and not a lot of folks realize that. They are actually looking at making sure that social determinants of health is a required data capture. So I linked an article here that's actually really fascinating about why they think it's so important to have this, because we always talk about the wellness of our patients, but those things that we don't know are those things that are going to impact our patients the most. I think we learned this during our COVID era, is kind of what I've been calling it at this point, is where we started to do those telehealth visits. And we had a provider who was doing a telehealth visit on a patient that on a child that was sick, and the child literally wanted to take the phone and walk him all around the house and show the provider his toys and things like that. And the thing that the provider noticed is that it was extremely warm outside, and they were under a lot of fans, had fans going in the living room, had fans kind of going everywhere. And the child had recurrent ear infections over and over and over again. So they were trying to figure out ways, but they never would have realized, hey, do you understand, as part of it, as that for that little guy, part of the reason that he continues to have those ear infections is he's sleeping under the fan. Can we move the fan off of him where it still gives him air in the room? And that's just an example of a social determinant of health, is that they didn't have access to air conditioning, which is an actual ICD-10 code. So next slide, please. All right, so social determinants of health, they have to be identified during an assessment, must be documented. I'm going to say that 500 more times because it's so important if you're going to reference it, especially for that medical decision making. You are encouraged to utilize those Z55 to Z65 codes. Those are where we're going to talk through those identifying social determinants of health. Are you identifying the needs of your patients? Do you have resources in place? So one of the things that I gave you a list earlier is like AuntBertha.com. If you go on there and you're like, man, the senior center gives out food every Tuesday, you can actually add that in and they will verify the information, and it becomes part of your community record. So I like that because you can add things that you may be aware of and refer patients over to that. If you have a paper version of a resource list for your patients, the greatest thing you can do is add a date at the bottom of when it was updated, because there's nothing worse than handing something to a patient and somebody, maybe something's closed that wasn't available prior. Or maybe, the senior center is only open on Mondays and not on Fridays, and we're giving the patient something that's out of date. So what are you currently doing that you can improve on or you can add value to? Maybe this is new, maybe social determinants of health, and I think we're going to hear about this more and more as we really go into that quality initiatives that we're all looking for, or we wouldn't be a part of this project as it is anyway. But are there ways that we can streamline our processes to better enhance the patient experience and staff time? So thinking of social determinants of health, part of it is community health workers. And those folks are that have, maybe our referral person is fantastic with patients. And maybe a piece of that is she spends a few minutes going over social determinants of health with the patient. There are ways that we can do this. Next slide, please. All right, this is going to be the fun ones. So I kind of am trying to give you a snapshot of some of the things that we don't think about on an everyday basis, right? These are all of the codes related to housing. So you've got everything from homelessness to sheltered homelessness, meaning that they're doubled up. They're living in a shelter like a motel. Maybe I'm living on a couch of a friend. Unsheltered, meaning not a place meant for human habitation, abandoned buildings, cars, parks, sidewalks, and actually residing on the street. Then you have we're really not sure, we have inadequate housing. And here's the one I was telling you about inadequate housing, environmental temperature, lack of AC, lack of heating. And everything from, lack of electricity, gas, oil, water, to then other things such as infect like pests, or maybe even things where the ceiling is falling in or things like that, unsatisfactory surroundings. Maybe our patient is doing okay, but it's housing instability. So there's a risk of homelessness for our patient. Or their house, but they have been homeless in the past 12 months. And then other problems related to. So, we have patients sometimes that come in and they're really struggling with their house is getting ready to go into a foreclosure, or maybe they've already paid off their house, and especially like right now where tax bills are due. Soon folks are going to be on list where if they haven't paid their taxes, then, the county starts that process. So I kind of wanted to point out our problems with creditors. And then maybe we don't have enough yet, but we know that there is some kind of housing or economic circumstance that is affecting our patient. So right now it's just unspecified. Maybe the next time our patient opens up a little bit more and we're able to get more information on housing. Next slide, please. All right. So you got all of that for housing, but I wanted to point out the difference. So here's food and transportation. What do we hear the most of? Our patients don't have access to healthy food, or they lack transportation. So, as you're going through, there are some here. So food insecurity, and then inadequate food or lack of food. For our transportation, it's excessive transportation time. I was listening to one of you talk about you drive 40 miles to get to your patient, and we are all over our state meeting with providers. And so I always kind of giggle sometimes about the time that we spend in the car. I think I do more phone calls in the car, work calls, than I'm willing to admit. Or maybe it's unreliable transportation, or it's unsafe. And then the other one for our really rural folks is that unavailability or inaccessibility of healthcare facilities. So if I live in North South Carolina, the closest one for me would be to Orangeburg, or Bamberg. But if I need to, maybe I'm in an area that is a rural maternity desert. So I have to travel up to Columbia if I get in trouble, or I'm in Allendale, and where am I going to go have my baby? So these are just kind of things that I wanted to make sure we pointed out today. Next slide, please. And then utility difficulties. So we've talked about the housing, we've talked about food and transportation, but we can even go further. So we have the one that we talked about with the housing a minute ago, and I wanted to kind of point it out here as well. So it's the same code, but it's that lack of AC, lack of heating, electricity, gas, etc. The other one that's very interesting is the lack of safe water. The EPA has been doing a lot of studies lately about the lack of safe water for folks, and especially if they have well water and what can be in the well water. And then everything from our basic services are unavailable. They can't get internet, or maybe they're in an area that doesn't have it yet, like broadband, for example. They're unable to obtain utilities due to inadequate physical environment. So maybe they're in a structure that they can't get internet or electricity to. We have folks, especially some of our unhoused folks, who, will find shelter wherever they can. And that might be a garage, and that garage may not have access to electricity. Next slide, please. All right, so interpersonal safety. I think this is probably one of the hardest ones to address and look at as social determinants of health. So everything with discord with your neighbors, landlord. There are a lot of the conflicts, whether it's parent, biological child, parent, adopted child, stepchild, etc. Problems in relationship with spouse or partner, disappearance of death or family members, Alcoholism and drug addiction in family, I think that is a great one to really utilize, because not only would we realize our substance use disorder issues, but that's something that can affect that interpersonal safety of our patient and our history of. Could be everything about anxiety about a sick person in their family, or even they're isolated. And then primary, so other specified problems related to primary support group. There's just family estrangement. There's high expressed emotional levels within the family, problems related to primary support group, and then other specified psychosocial circumstances at risk of feeling lonely, religious or spiritual problems. So as our elderly, of course, we know that part of that is we worry about them feeling lonely and making sure that we have it. Kind of a funny one as part of it is there's even a Z code that you don't get along with your in-laws. So any of you that are married, there is a code for that. We can add that for you for your medical record, should that be the case. So sometimes, you got to make a little humor with some of this, because if not, I'm just reading you a bunch of Z codes here. All right, next slide. All right. So the additional ones that I kind of wanted to point out that really affect those social determinants of health is extreme poverty, all the way from low income, or maybe our folks have, so like in South Carolina, for example, right? We did not expand Medicaid in South Carolina. So maybe they don't have access to their low income, but maybe they make too much to be on that. There are ways that we can actually use some of these Z codes to highlight that. Or insufficient social insurance welfare. And then we also have our reading levels, or maybe folks that have no GED, they didn't complete high school. And then the last one here is one that I think that we can all really start to use, because there's a lot of our folks and our front desk folks would be beneficial in these conversations, because there's a lot of times that our front desk folks are actually spending a lot of time with the patients, and they're talking with the patient. They're having a very hard time understanding either what they're filling out or completing medical forms. And with our nurses, where, you're trying to explain medication, a provider gives me this pill. How often do I take it? Okay, I take it 3 times a day. No. You take it 1 time a day, understanding those medication instructions as well. Next slide, please. So what's next? All right, so those practitioners who furnish those risk assessments, you're actually going to refer patients over to relevant resources. So at the beginning, we started talking about making sure those lists are updated. And that's why some of those websites that you can actually add in resources that they don't have on file. Not only is that going to make your community stronger, but man, that's going to make your clinic have so much information available to your patients. You're going to refer them over, and maybe it's stuff that we want to make sure they have appropriate follow-up. If we identify a need of, needing access to food, well, then let's go ahead and make sure that folks have access to where some of those free, I call them the red boxes, in our community. There's one like literally up the street, a food pantry that I put food in regularly for folks. And so like, where are those? But there actually is starting to become these places that you can get a list of all of the free food pantries in your area. So identify those resources. I'm going to say that again. Identifying the resources for your community is only going to make all of our patients healthier. And then social determinants of health is going to be more and more important as that time goes on. Talk about having those quality metrics. If we can identify our patients, whether that's their risks or whether that's their access to everything from food or housing needs or even transportation. One of the things we've done here is we've really been looking at some of that rural transportation. And, my joke is we need a rural Uber, and we don't have that. They won't take folks out to certain areas. But the family member will charge them $20 to come into the office. And so could we make that patient a telehealth patient instead of that patient having to, give $20 to their neighbor to get them to the office and then $20 back? And that sounds a little crazy, but these are true stories. I'm pretty big on using real information. Next slide, please. All right. So we talked a lot about social determinants of health. I've got some cool resources. So my contact information is going to be further down in the presentation. But if you're on Epic, I have an awesome little spreadsheet that I didn't want to upload because it's kind of big and massive, but I'm happy to share that. But what else could you be missing? So, we're talking about social determinants of health. We're talking about making sure that we understand our patient. But if it's a Medicare patient, you're also able to get additional revenue that comes in separately, whether that's principal care management, chronic care management. So principal care management is one condition that's affecting the patient that is a chronic, expected to last more than 6 months or until death. Chronic care management is two conditions, 20 minutes time. And these are non-face-to-face things for the principal care management and chronic care management. If I were to ask you as a provider or ask a nurse or anyone within a practice, can you tell me the patients that call you the most? Nobody answered, please. But can you tell me the patients that call the most? Are those the patients that we're the most worried about? Or are those the patients that sometimes they're calling because they're lonely or they have other concerns or issues? Patient form completion. What's your process? Do you charge for it? Or do you feel like this is part of a service that you do for your patients? And that is a mixed response when I ask that question live. Some folks are like, yeah, it's just easier for us to do it. We scan it in. Some are like, have you seen the length of these forms? And I'm like, all right, but you have to be consistent. And then for e-visits and telehealth, so we were talking about, a second ago where, the neighbor was charging $20 to the gentleman to come in and have his visit. And could we have made that patient a telehealth visit? So the American Academy of Family Physicians, they have an awesome little breakdown of billing and coding for that and kind of like how you actually can get paid and code for all of that. So I just wanted to share that resource as well. And then next slide, please. All right. See, we got this now, Kathleen. All right. So wrapping up, social determinants of health are in everything that we do. I've made some jokes about different things, but if I were to say, has anyone been impacted by drugs or alcohol in your family? I guarantee you that there's several of us that could have that Z code tied into us individually for social determinants of health. But ask the questions, learn the resources. And last but not least, and I mean this, or I wouldn't say it, LaShonda knows me really, really well. Don't forget to ask for help if you need it. I am only an email away, and I am more than happy to sit down, have a conversation, and say, how can we help you where you can help you serve your patients better and or the community? So if you want to go one more after the questions, one more. There we go. All right. There is my email address. It is chambers@scorh.net. I am happy to answer any questions, but I actually, once you get to that, I'm gonna have to start changing this slide. So I give you the email after I say that you can email me. I should give you the email address probably before I ask what questions you have. So I'll give you a second if you want to write that down, but I know Kathleen will get you the presentation. And then let's talk. What questions do you have? What can I help you with? As you can tell, I'm pretty passionate about the work that we do. I'm very proud of it. And I now get to take a lot of this national. I'm getting ready to do a presentation like this in March for rural health clinics across the country. So trying to access information and make folks understand what's available. So I will be quiet for a second, and I don't see anything in the chat, but I could have missed it. Let's see. All right.
Shannon, it's Suzanne,
Yes.
and I love this presentation. I will gobble up all those resources you gave us. I don't know much about Z codes, but I do know about patients in their home. And I do deal with the bed bugs, and I do see the lack of air condition, and just firsthand, it's easy for me. I don't even need to fill out forms to find out. I fill out the forms for the physicians. I'm their outreach, and I love this presentation. Thank you.
Absolutely. I figured there would be some people that actually, like, when you see those codes and you're like, we always think about when we're talking like ICD-10 coding, right? It's hypertension, it's diabetes, it's I sprained my foot, I hurt my shoulder. But it's those other things that impact our patients, and that if, we've got patients that constantly have infections and we have a bed bug problem, how do we fix that part to help with the, infection piece for our patient as well? So, but if you ever get into something and you're like, hey, this one looks weird, or what would you do? Of course, I'm happy to help you.
Thank you, Suzanne. And Suzanne, you may remember from her introduction, she's the community paramedic. She's in her car right now. I think every time I've met with you, Suzanne, you're in your car. You're always on the move. So she is, boots on the ground in the trenches, visiting patients in their home. She also works with community health workers that she can make referrals to on her team. And one of the things that we've been talking about in our Novant Health team is getting more of the work that's being done paid for, because they do have community health workers, and their system is trying to figure out they were originally brought on with some grant funding, but of course we want to sustain that program and grow it. So it's something that we're talking about in our monthly coaching sessions, and we'll talk some more about it later this month. So Shannon, thank you for being such an excellent resource, and we'll probably be reaching out because we have some ideas of what to do next, and we'd like to get I'm sure some of your input. The other thing is Constellation is working on a billing and coding training program. And we're going to be doing some workshops for some groups along the way as we build out this training program. So I'll be contacting you to loop you into some of that as well. It'd be great to have your input into that work.
Absolutely. For the community health workers, there is a newer code. It's community health integration. So that's something that I would highly recommend looking into, because you're going to see a lot more. And I do have in writing from CMS, which I'm happy to share, that even covers our community paramedics going out and doing it, because we have a big community paramedic thing here in South Carolina as well. And we work really closely with the EMS Association and pilot projects where they're partnering with a community paramedic is partnering with a rural health clinic, and we're able to get reimbursed for some of that as well. So always happy to share any education.
And that's exactly what we've been talking about, Shannon. I'm using the new CMS codes for Medicare patients around community health integration and principal illness navigation. And so we're exploring the use of those codes for the work that they're doing, because that's not, as you said, just for community health workers. It's for all auxiliary staff that are doing this work, and they get called different things. Sometimes they're peer support, sometimes they're community health workers, sometimes they're called a number of things, and they are a number of disciplines as well. So I'm so glad we had this presentation today, because it's right in line with the work that we're doing and with part of the work of the Constellation Regional Collaborative, which is to not only, and the Learning Collaborative is not only to implement all of this good work, but figure out how to get it paid for, sustained, and grow and develop it. So we'll be aligning the reimbursement piece in year 2 of the Learning Collaborative very closely with the clinical and community linkage work that we're doing is how do we pay for all of it? How do we sustain it? How do we grow it?
Absolutely.
Eek, that was me. Sorry. I took myself off mute because I did have a question for you. I agree with Suzanne. This was just awesome for us to listen to. It's really exciting, actually. I had a question. You said something about dropping these codes as an office visit, and then you mentioned something about being seen prior to discharge, and I didn't capture that completely. I'm wondering if you would be able to explain, if you have time to explain that a little bit further.
Yeah, absolutely. So the G code that Medicare has in place, the only thing that you can't do, and I think once you get the slides, it'll help a little bit, but that G code is G0136. So, and that's that social determinants of health assessment. And so pretty much you can get that as part of like reimbursement, or if you're an RHC and FQHC, it's kind of part of that reimbursement, right? So we get an all-inclusive rate. We could go way down the rabbit hole if I wanted to here. You are allowed to do this G code in an outpatient setting with the exception of discharge visits. So if you're discharging from nursing home, if you're discharging from hospital, things like that. But if it's an actual office visit with a patient, you can do this every 6 months. The code says not more often than every 6 months. So I hope
what if it was like, say, a hospital follow-up visit?
Yeah, so hospital follow-up, right? Just do it before that discharge. So if you did it as part of a hospital follow-up, but the problem is it's an outpatient setting. So that's where it gets even weirder as we're thinking about coding, right? It's going to help if you're doing it as like follow-up, right? Like 99232 off the top of my head. I can't even remember if that's really right anymore, but that's our subsequent visit for how much time we've spent with that patient during those rounds. You could be addressing this, but you're not going to get paid because that's in an inpatient setting. Part of it is if you're addressing or bringing things to the forefront is when that patient checks out or discharges home and gets to their primary care, they're going to have access to your records and to your notes, and they're going to pick up on things that need to be taken care of, whether it's lack of electricity or problems with the family. I think we see a lot in those hospital settings. And I've coded for inpatient, outpatient, you name it, I've probably done it because there's something wrong with me apparently, and I love to learn. And so I don't personally like how it's written because there is some room for interpretation, but with them saying clearly with the exception of discharge visits, that's why I'm encouraging folks to do it. And it says outpatient setting. I was like, that violates the own process there.
I guess I'm thinking of it as like stroke patients, for instance. They're discharged. We've addressed their needs in the hospital. Then they're seen as follow-up in the office, and they could then drop that code with communication from what occurred in the hospital or what further needs they may have with Suzanne, say, following them.
Absolutely. And
every 6 months.
Yeah. And the record would indicate as part of the provider's note, like that office visit follow-up, right, would reference the prior social determinants of health, is because that becomes part of that record for that visit, right? That's the review of records. In CPT coding, we can pull in everyone else's records and add it for medical decision making. It's the same thing for social determinants of health. So that's and then Suzanne would get that information and be like, okay, so I've seen this problem, or when I go out, I can expect this. but she's going to pick up on other things that the patient didn't tell you or may have been too embarrassed to say if she's doing home visits.
Yeah, I mean, that's like the fantastic thing about, is there competition on this? Is it like the TCM codes? I'm not so familiar with coding, as you can tell. So
It's
maybe
not
asking questions that I should know, but
no, you're good. So there's not. I think that, we've always kind of, like the transitional care management codes, while I love those and you got to get them in a certain time and a certain, the key with transitional care management is the medical decision making has to be moderate or high, which I always giggle because any patient that's been in the hospital, I don't think we have a low medical decision making normally when we get them out. So I don't know why they don't just make it a time-based code. That's my personal opinion, but I hope I answered your question, but I'm happy to have a separate conversation should you want to talk further about it. Absolutely.
yeah, that was great. Thank you so much, Shannon.
Yeah.
And I'll just add to that the studies have shown, and Shannon, I'm sure you've seen these studies, that as far as any competition, and there's not, because you can build the codes simultaneously because they're for different kinds of services. But for transitional care management, for Medicare patients, the studies show that only about 17% of eligible patients ever get that code billed. So there's a lot of missed opportunity for there's seen to be, and you know this, Erica, from the Compass study, that if the medical offices were already billing for TCM, then the Compass implementation team didn't want to do that, didn't want to be in competition. Yet when we study it, we see that there's only about 17% of eligible patients that get that code billed. But then for Medicare patients, and a good chunk of yours there's those new codes that there are no competition for them. It's just partnering, and you've already got the providers in your system is partnering with a provider to do that initial visit and to put at least one social determinant or health-related social need in the plan of care, and then make the referral for the auxiliary staff like Suzanne and community health workers and others to follow up. The provider still has to do the billing, and that's in your system, that shouldn't be an issue. But when you're not in the same system, getting the provider to share the piece of the pie for the people who are out doing the work, the auxiliary staff out doing the work. And that's some of what we can talk some more about later this month, because I think you guys are in a really good position to be doing some of this billing.
Agreed.
Any other questions? And Sydney, I don't see anything in the chat, but all right, perfect. I can see you're shaking your head, so I want to make sure I didn't miss anything there. All right, Kathleen, I guess I'm going to turn that back over to you.
Well, thank you. Thank you so much, Shannon. That was a great presentation. We truly appreciate it. We really do. I was going to open it for questions and discussions, but we went right into it. So, is there anything else that anybody needed to discuss regarding the Learning Collaborative that you had any questions or about? If not, we will be saying thank you for joining us. Dr. DePetti, oh, okay, you're saying bye. Okay, I saw you come on, your video come on. I wanted to make sure. All right, well, we at the Constellation Regional Collaborative team want to just say thank you again for joining us. And Shannon, thank you very much for coming and presenting. We